All right, so let's get this started. My name is Damon.Haycock. I'm the Community Engagement Director for Benefitfocus. And today I have the pleasure of being with Chet Loftis, the Managing Director of the Public Employees Health Program in the state of Utah. Chet, thanks for joining me today. And why don't you tell us all a little bit about yourself?
Well, thanks, Damon. It's always great to see you, even if it's virtual. A little bit about me. Grew up in Chicago and I went to school out in Utah, and I've been here for an awful long time now. I'm a lawyer by training, and along the way, I've had the chance to be a legislative staff attorney in Utah, which is kind of what got me into healthcare. And then I spun out and did some lobbying, both for the Medical Association and the local Blues Plan. And that background put me in a pretty good spot when PEHP, where I'm at now, was looking for somebody to come and run the organization that needed both the healthcare and the political background. And so I came and did that, and I've been there now almost 10 years.
So I'm going to assume that's why you sound so polished every time you speak publicly with all your experience lobbying and testifying to the legislature. Is that it?
I have testified to the legislature an awful lot over my days, that's for sure.
So Chet, why don't you tell us a little bit about your health plan and highlight some of the impactful programs? I understand you've been there, since 2011?
Yeah. I think we're coming around on 10. It's about 9.5 now. So we're kind of an interesting animal, right? And so back in 1979, the Utah legislature, maybe 77, but it's kind of in that space, Utah legislature essentially said that rather than having a kind of an outsourced RFP type of process for the health plan, said what they wanted to do was actually bring it in-house and kind of create their own health plan within state government. And so healthcare and health insurance went from the finance office within the state to coming within the retirement office. So the retirement office in Utah is called URS, and it applies to every public employee that works, for the state or university or those kinds of things. And so it's a unified system. And so there's really not a lot in common, as you know, between running pensions and running a health insurance company, except they both deal with benefits, right? So we were brought into that organization, and we're a division within that. And right from the beginning, and also over the course of time, we've really developed into a regular health plan. We function just like a health plan would. We have our own contracts with providers. We have our own customer service. We have our own claims processing system. I have actuaries and data analysts. I have a clinical team made up of doctors and nurses and pharmacists. I have my own marketing team as well. And I have a marketing team because the way it works in Utah is that state employees have PHP coverage. Any other public entity can have PHP. So we aggressively go out and try to convince people that PHP is the right plan for them and their families. And so we do that. And so in addition to medical, we also do life and long-term disability and dental insurance as well. So it's kind of different that way.
So you guys serve about 160,000 lives, pre-Medicare lives, is that right?
Yeah, that's right. We have probably about 160,000 of medical, kind of, again, everything that we do is group insurance through employers, of course. But then in addition to that, we have about 15,000 Medicare beneficiaries that we cover on a Medicare sub policy.
Is that, I assume that's a national policy, is that correct?
We run it through Medicare, and then we actually do all of the regular Medicare sub ourselves.
Oh wow, okay.
Yeah, we run it just like any other health plan that we operate. We set the rates, we set the different plan designs that are, of course, based on what Medicare allows us to do, those kinds of things.
No, that's awesome. When I first met you years ago, I remember hearing the story about Utah sending folks to
Right.
Mexico to buy drugs for specific types of chronic conditions, or maybe it was one chronic condition. That's such an amazing, innovative idea, and I'm really curious as to how you were able to accomplish it. And could you kind of go into some detail about that?
Yeah, happy to. So, I'm really a policy guy, right? And what was interesting to me is when they came and talked to me about maybe running PHP. I'd been in a space where it's like the only way you make progress is if you pass a bill. And so what was really fun is when they said, what about PHP? And I'd always been more on the private side of this stuff. I said to myself, you know what, I bet you we can do some fun things, right? And so I very much look at PHP, and I look at actually any state agency as one in which the opportunity to do new things is there. There's more of an appetite for that, at least in my experience. Our legislature, at least, likes the idea of innovation. They like to move things forward. A lot of time, they're kind of uncomfortable with pushing the private market forward faster than it's ready to go. And so we'll do a lot of like pilot projects and pilot programs and the like for the state, so that's kind of fun, right? So a couple of years ago, we had a legislator who kind of heard about the idea of cash back. And I think that some other states have kind of looked at that and moved in that direction. The whole premise is that you find cash savings of some sort, and then you share those back with your membership, right? And so as we looked at it, the bill passed. We didn't have any opposition really from any sector, right? And we looked at the different ways in which we could implement cash back. And one, of course, was to say that if you go to a lower cost site of service, we can give you cash back, right? And lower side of service, of course, you see that all the time with imaging and with surgeries and the like, if you can go to freestanding surgical center. And so we built up that, right? So that now if you go to one of those things, we'll pay you money and we'll share that with you, right? And as we continue to think about that, we really said, drugs is a real problem. And we were specifically looking at specialty drugs for things like, MS or Crohn's or the like. And we had looked into tourism before, medical tourism before, but it's really hard to get people excited about that to go. And frankly, our rates in Utah, if we can get you to a surgical center, are pretty competitive, right? So there's not this big push, not this big need, right? And so as we looked at it, we said, what about specialty drugs? And now that we have this cashback mechanism so we can share money with the member, maybe we'll get some folks that'll take us up on that, right? And more importantly than anything, at least in my role, is I feel like I need to do innovative things in order to show that I care, because I do. I do care about taxpayer money. I do care about trying to lead out a little bit more rather than kind of following the crowd, because I think that's what my legislature looks to me for, right? So we went back to one of our contacts we had on tourism, regular medical tourism, and we said, what about pharmacy? And we worked it out, and we're able to make sure. And again, I'm in a good spot because I have three pharmacists on my staff, so they're able to look at all those kinds of things, look at the chain of custody, look at all the issues, have people fly down, make sure we're good with things. And so it all checked the boxes, and so we started flying people down and paying $500 each time they went down, and made sure we took care of all the accommodations, made sure it was really easy for them to get back and forth across the border, all those kinds of things. And so we were up and running and doing that. And we found another opportunity in Canada, just right in British Columbia. And so we've got that all ready to go, except with COVID, everything is closed down.
Right.
And I do think that one thing that we'll do as a result of this is probably increase the amount that we're giving as an incentive, that cashback amount. Well, there's a good chance we might move that closer to $700 or $750 or maybe $1,000.
Now, you didn't have any issues with potential rebating, right? You were able to kind of skirt that with the process that you guys got approved?
Yeah, so, we've never been an organization that chases rebates. We've always been one that says we want to find the lowest cost drug, right? So we push generics and we do all these other kinds of things that try to give us the lowest cost. And then we've really got a pretty good beat on what we get back in rebates on things, right? This is a situation where we've completely come outside of the normal chain with the PBM and things like that. We just send them down and we get billed through a completely different mechanism. And so what it in effect does is it takes it off of our PBM bill and puts it on a different bill.
Oh, good deal.
And then when you look at it, we were still saving half. These are drugs that would on average cost $50,000 a year, and
right,
with everything said and done, we were looking at $25,000. So we're saving $25,000.
It's big money. Have you been able to tabulate so far what you've saved?
You know what? We were into it a full year before we kind of hit COVID. And we had the interesting thing is that our local paper, right, the Salt Lake Tribune, kind of picked it up in the beginning, and that kind of created more media attention than you can imagine, right?
I imagine.
And then they came back around and they actually interviewed our patients that were going. Now, we only have about 400 patients that are actually eligible for the program, and we had maybe 12, 13, 14. But, for those 12, 13, 14, I was 25,000 a piece, and more importantly for them, they enjoyed it. They thought it was good. They enjoyed getting the money back. It was something they they would connect with Christmas a little bit, right? Because if you're getting $500,000, that can help out that way. And of course, they needed the medication anyway, right?
Plus, you also proved the concept that you can do a cashback tourism type of process,
Yeah.
which you're able to then leverage on your next piece, which is up in Canada. So I think
That's right.
that's really awesome.
Yeah.
So along that same vein, Chet, what are you doing new now? What's the next innovative thing that you guys are looking at, or what creative processes or programs are you looking at to address issues today?
Yeah. So, COVID has kind of been interesting again for that program because, we were really ramping up because of the last, the last thing that the Salt Lake Tribune did, and they interviewed some of the members that were going, and they said nothing good to say about it, right? And so we had all these people coming in, and so that's kind of slowed down, and then COVID's kind of slowed down some other efforts a little bit in that regard. But over this last year, we've actually implemented a whole new IT core system. And so what I can tell you right now is that is like central to everything we're doing, is
Right.
trying to get that system up and running and the like. Along the way, some interesting things that have happened that have been kind of fun is that the legislature here in Utah has been really concerned with the cost of insulin. Vial costs about $300, right? Doesn't make a lot of sense, and those kinds of things. And they've also been really interested in the whole PBM world, trying to get at the heart of that. And part of that is because we have Senator Evan Vickers, who is a pharmacist, and he is very, very knowledgeable of these things, and just really is amazing. Just as a pharmacist to be great, as a legislator to be great, you put those two together, and he's really an impressive person when it comes to his depth of understanding on these issues. But what we ended up doing is we tried to partner with the state to figure out a way to get drugs, insulin, right, to regular citizens in Utah at our post-rebate price.
Yep.
So what that means is, and that if it's, the vial is $300, and we've got like, I can't remember, it's like we get a lot back in rebate. I'm thinking 100, 150, maybe even $200.
Yeah, at least it's pretty high. The rebates are pretty big on insulin.
Yeah, it's pretty big on insulin, right? And so what we do right now is we have been able to work with our PBM, and we've been able to run a program so that anybody in the state of Utah, right, can get a card from PEHP, a little drug card, right? Take that to the pharmacy and then get the cash price, meaning the post-rebate price. And then what happens as part of that is the state essentially pays the full amount, and then it waits for the rebate to come and reimburse the state for giving it at the post-rebate price.
You just kind of skip that last part. A lot of plans will collect rebates throughout the year, and then they'll pass new rates the next year, and it'll go to reducing the cost of those rates or some other program that they're trying to implement. So it's a similar pass back to the member, except it's direct one-to-one to the people actually using the drug instead of offsetting the program as a whole.
That's right. And what we do right now is, it's really kind of interesting how RX works, of course, in terms of, the patient actually is paying the full billed rate, which is unlike the doctor's office, right, or the hospital, right? That you get the discounted rate, and that's what you pay off of. In this case, the member pays the full amount, and then it's like the pool. It's like the whole plan benefits as a result. And sometimes it gets passed along, as you just mentioned, in how we do co-pays and those kinds of things, right?
Right.
But since these aren't our members, what we're trying to do is to say so maybe you don't have insurance, or maybe you have a high deductible health plan, and you're not going to get that post-rebate price. What we're doing through the state risk pool and on behalf of the state is to say we're going to give you the value of what that insulin drug is at its real cash price, which is after the discount, meaning after the rebate.
Yeah, it's rebates at the counter, and some
right.
plans have looked at that.
That's right.
Some can afford to, some really rely on that revenue source to offset the costs and the contributions that may start to dwindle over time from the employers. But I think it's a great program and something to think about for a lot of folks that are looking at how do I get the cost down at the counter for my member who's struggling to pay on maybe a high deductible health plan, like you mentioned, or has a really high copay for a specialty drug.
Right, and
so it makes sense.
And again, the weird twist on this is that our own members, we take care of them already. We have different ways that we pay because we consider this to be within preventative, and so we're able to give them a lower cost.
Good.
If they'll engage in different things, right? this one really is where we as a state entity, a state agency, is saying that we're going to help all of these people that are citizens of Utah, even though they're not members of PHP. And so that's been the fun part. And we anticipate moving this maybe to EpiPens next, because it looks like there's a sufficient difference between kind of post rebate price and what's generally out there.
So something that I was thinking about when you're talking about your innovative programs, another conversation you and I had was around air ambulances.
Oh yeah.
And you were doing something that I almost tried to do in my home state for a while.
Yeah.
And I threatened it, which actually got my air ambulance companies to the table, and we were able to negotiate a percentage of Medicare. But I used your idea to as kind of a, I don't know, a stalking horse or whatever, to try to get them to come to the table. Do you want to talk a little bit about paying the member versus paying the provider?
Yeah. We we always say that we don't negotiate. We can't negotiate with terrorists. And
True.
frankly, you do get into spaces in this business where it's just crazy, and what's really fun right now, just to kind of move, kind of transition in this a little bit, is that, my data folks are doing a much better job of telling me when I've got outliers on payments, right? And it's just the craziest thing when you are paying for like percent of billed, even on outpatient, that you can get these really screwy things at a particular hospital, right?
Very true.
But that's the whole purpose here, is that when you start seeing things that are completely outside of what you should see in the market, how do you deal with it, right? And so air ambulance, very difficult. There's not a lot of state regulatory opportunity there because it's federal, and the federal government can't seem to get these kinds of issues taken care of. And so what happens is, we have rural places in Utah where somebody will be out at a national park or something fun like that and get hurt. And then you have the air ambulance, and the air ambulance will charge them $80,000 for something that, the market rate's $20,000. And so, the first thing we do is we send it to the member. I will tell you that we continue to kind of fine tune our approach on this stuff a little bit. And one of the things we're doing a little bit more of is paying a little bit more directly to the air ambulance company. And then the idea of giving a little bit more to the member, so that there's maybe taking some of the initial pressure off of the member, so that they're not just holding the check, hoping to get an ideal deal, but at least giving some to the ambulance company, air ambulance company. So maybe they come off a little bit, and then also giving enough to the member that they can continue to negotiate in a way that hopefully gets them completely out. We really have, we've tried to help members out in terms of if there's any kind of credit reporting that's done. We've taken that. We have our attorneys that are willing to represent these folks in court, because we think that this would not be upheld by a judge or jury. This idea of taking advantage of a person, we call it in the law an unconscionable situation. So we continue to work on it, but the good news is that we have been able to contract more with these air ambulance hospitals, and we continue to be very active in terms of making sure we don't overpay, and at the same time not leaving our member in a lurch.
That's really good. It's really good. So we couldn't have a conversation today without talking at least a little bit about COVID. And I know a lot of folks have heard a lot about it. Some people even think it's pretty saturated. It doesn't appear to be going away. Can you just briefly talk a little bit about how it's affected your plan and how you're going to handle this type of thing moving forward, with maybe pent up demand with elective surgeries, travel restrictions, those types of things? Can you kind of touch on a few of those for us?
Absolutely. So overall, our healthcare costs have gone down. When we first got to the beginning, kind of that March, April, it kind of went down quite a bit, and then it kind of came back up, and kind of as we look at it over the year, costs to the plan are still, down. I kind of felt like we were going to start getting to a point pretty quick where the COVID costs would be increasing. We'd get back to the regular elective cost. I mean, Utah has been kind of a non-lockdown state, trying to be really prudent, a lot of mask, wear your mask, all those kinds of stuff, but not really closed down, so to speak. So I've been expecting kind of the pent up demand to kind of hit, and so far it really hasn't. We're clearly seeing a spike right now, so we'll have to see how that goes. But our approach this year, in working with all of our groups, right, and so we work not only with the state of Utah, but large employers like Salt Lake City and others. But what we've done is, on the renewal, we've essentially treated it just like any other renewal, right? We're trying to take COVID out both the plus side and the minus side from a healthcare cost standpoint, and just saying where do we think that healthcare costs are, having a regular renewal, and then we're letting our reserves kind of be the buffer for any increased costs that happen as a result, even if it's the vaccine that ends up, we don't know what the cost of the vaccine is going to be. We certainly hope everybody gets one for sure. So there may be some extra costs there. For the state risk pool so far, we've had like $4 million in total costs just related to COVID for 74,000 members. We've had, I think it was 46 people that have been hospitalized. Average cost, well, the median cost is about 25,000 on those, with some really, really high. And so overall, we've got a good buffer in our reserves. And so we're just going to see how it rolls out. And at some point, if things got really tough, we may have to build back the reserves, ask the legislature to come in and do that. Right now, we're very, very healthy on the reserve. But we're really treating this like a one-time event rather than an ongoing one for purposes of deciding what should we be building into the budget as renewal.
I think your actuaries would agree, and my experience with actuaries is don't swing the pendulum too far one direction or the other year to year. Look at those averages and understand that you need a sustainable rating structure that you can live with instead of doing this up and down each year and really messing with your population.
Well, we started, and my actuaries are in house, and so it means I can talk to them as much as they'll take my call, right? Which is most, they do a pretty good job there, right? But as we started talking about kind of all of the different, assumptions we were making, and this is happening this week, and this is happening next week, and it's like, well, isn't this what the reserve's about?
Right.
Isn't the reserve meant to treat something that's really kind of a one-time event, we hope, and be able to kind of give us that buffer, because that's what it's there for. We've got, 100 days of reserve or whatever it might be, for that purpose, realizing that we have to have 50 in order to feel like we're really solid. And so at this point in time, we feel like we're in a good space to be able to manage that.
That's really good. So let's shift gears for a second. Why don't you tell us something about you that people generally don't know? Let's get to know Chet a little bit.
So I would say my first job out of college was at the National Security Agency. And one thing I learned about that job was you couldn't take any work home with you, or else something bad might happen to you. Right. and learned some other good things along the way on that one. That was a fun first job getting out of college, and I didn't do it for a long time before I realized that I probably needed to get some more education, so I went back to law school at that point.
Awesome. You also ran for the Utah House of Representatives, right? 2014. Why don't you give us a little bit of information about that? That's not something you hear about health plan administrators every day.
Yeah, I'm a policy guy, and part of my challenge a little bit is everybody looks at me as the healthcare person on the Hill, and at some point I'd like to maybe say a word or two about education or some other issue, right? And if somehow if you're the legislator, they'll actually, they'll actually come talk to you about things like that, right? So I actually ran in 2010.
Oh.
And I ran again in 2014. 2010 was interesting just because that's when the ACA passed, and it was just kind of crazy, right? And we had 3 people, and we do a convention system in Utah, and I won't go into the details on that other than to say 130 people choose who will be the representative for that party, right? And so I had folks on this side, folks in this side, and like the 20% in the middle is where I was at, and that didn't get me to the next spot. And then I ran again because a good friend of mine had just retired. I actually got gerrymandered out of my previous district into somebody else's district, right? And then and really good friend who was the legislator at the time, knew him from college, all that kind of stuff. And he decided to retire, and so I decided to jump back in, and it was crazy. It was a mail-in type deal. It was me and a doctor, right? And his high school where his kids go to school is like right in the middle of the city, and mine is kind of on the outskirts, right? And so he had that advantage. And I will tell you, I think every old person in Utah, which is at least in our district, which is like the only people that really vote consistently all the time, they're all his patients.
Of course.
So worked really hard, had a primary on that one. We had like 53% turnout on a primary, which usually is like 8%, maybe 19% if you have like a mail-in type stuff. So we worked really hard, and I came less than 200 votes short. My wife has never been so happy in her whole life. I couldn't say anything. That's just not my nature to go and say bad things about people, and they
Yeah.
gave me such a hard time because they've been a lobbyist, my goodness, whatever you do, if you want to run for office, don't be a lobbyist first. And they said I had all these terrible conflicts of interest because I run a health plan that services the states. And it's like, well, I've been the lobbyist for the doctors, and I can tell you that they've got like 70 bills and they've got all the Medicaid budget. I'm going to tell you, he's going to have a lot more conflicts than I ever had, right? But at the end, I could talk about myself. I couldn't really, uh, you know, be negative about
Talk
somebody
poorly
else.
about other people. Yeah, you couldn't show the negative. You wanted to show the positive, which
That's
isn't
what that's
always
what
a
it's in for,
winning platform, right? In politics.
right? Well, but I will tell you, my wife, when she's not going to endorse you, would tell people straight out, yeah, this is why you don't want to go for this.
She cut right to it.
She might right do, right? But I've never seen her so happy in my whole life as the day that I lost, and she was just relieved. And I'll have to say that in hindsight, it's been just fine to not have that on my plate.
That's awesome. No, that's great. And I'm sure Utah and the health plan's happy to have you, and they feel like they dodged a bullet and not having you move on over to the House of Representatives. So at least you're there, and that's really good. That's consistent. Not a lot of folks in that position can make it 10 years before they get burnt out. I think the average I've seen is like maybe 3, 4 tops, and then they get tired of it, or they get pushed out, or they need to go do something else. So my hats off to you. My admiration for being in this role so long. That's a really good bedrock for that plan with all that institutional knowledge. You can talk the history of what's happened over the last decade. So, kind of heading back to your plan, and a little bit with you as well. Once this COVID vaccine gets released, and we're hearing good things every day. I think I saw something that Pfizer has a 95% expected rate of success on it. It's going to be trying to expedite the distribution channels. I think I saw that the other day, or maybe even this morning. But once that is out and about, what are you guys going to start doing next? And I'm sure you're going to maybe pick up traveling. I don't know if you miss traveling, getting on airplanes and going and talking to people outside of your office in your house. But what do you see is the next thing once that comes out? Do you feel like the employees of your state are going to all start coming back to work, and they're going to start needing the same types of sites of care where they're used to having them, or are you going to continue to push virtual types of care? I know your governor did something in September, releasing or kind of relaxing the rules on telehealth to help with this pandemic. What do you see as the next stage after COVID for healthcare? Sorry, that was like 13 questions in one, so feel
No,
free to
you're
pick
great,
one
man.
and answer which one you want.
I think it's going to be interesting to see. I think things are going to happen kind of slowly, to be honest with you. I think that we have reached a new normal of sorts. We've looked at telemedicine, and it went really high, and then it's kind of plateaued a little bit, and maybe it's going to stay there. And I think that's really been helpful for providers to kind of figure out that they can do that. I think they've been the bottleneck rather than us, frankly, on telemedicine. In fact, I was looking at a number the other day, and 51% of psychiatric visits right now are online. And so, there's some things that you're doing, and you're saying there is no problem with this. I think, for us, we've been completely virtual. You know, we have people that go in and make sure that we take care of the mail and those kinds of things. But by and large, we've been virtual, right? And I anticipate that when we go back to work, we're maybe going back to work a day a week, 2 days a week. But I think that we've probably changed that way. And in a place like Utah, it's a beautiful place, but sometimes we'll get inversions in the wintertime, and it's been pretty crazy this year, where it's so easy to say don't drive into work, and it makes a real difference up in our mountains and stuff like that. So
Okay.
I think we've learned a lot of good things as a result of that. I hope maybe that we're able to kind of combine the best of both worlds, right? Because clearly there's some aspect of these four walls of mine, right? you know, I mean, I've been here an awful lot, and I like people, and I like to be around people, and I like to connect and network and all those other kinds of things like folks like to do, right? And hopefully we'll be able to kind of reintroduce that back to take the best of that, and at the same time, you know, um, have the flexibility that we found, and more importantly, the ability to use technology in a way that saves time and saves money and everything else.
Yeah, I see a lot of that around the nation, folks really starting to embrace the idea of technology solutions, whether it be in point solutions, some type of voluntary benefit, new technology, new administration services, so folks aren't forced to go into work and push paper.
Yeah.
So it's definitely a trend that I'm seeing, and excited to see where it heads. So what keeps you up at night, Chet? What makes you worried outside of maybe having to wake up and come back downstairs or wherever into the same room and have another one of these Zoom or WebEx calls?
There you go, man. I would say number one is gene therapy drugs. Um, so given our size, right? So we have 170,000 members. We also administer our own reinsurance program. And so we're really sensitive to this idea of super duper high dollar claims and their potential for us and for kind of our groups. At the end of the day, we're self-funded, and so we just hold money for them. But we've recently approved a drug that's $2.1 million, and there are an awful lot more drugs like this coming down the pike. The good news is that where a lot of drugs, sometimes you can argue whether or not they're effective and whether or not you still may argue whether or not they're worth the cost. These are things that can really materially change somebody's life. And so that's a good thing. We really don't have really good pricing conventions in the United States when it comes to drugs, and so for me, it's how do we deal with those issues? I think they could be existential for us. Is there a way for us to start working with other organizations, maybe our size? Because the real problem is if you end up having, a glut, that you become your own little hotspot for a particular disease, right? So you have one family that moves into your plan, and you have 3 or 4 kids that all need this kind of drug, right? And it's really this lightning height, striking all in one place a couple of times. The idea with insurance, of course, is to take risk and spread it.
Yep.
I just don't feel at this stage, at least for my plan, that we have enough lives to effectively spread that kind of risk. And so figuring out how do we do that kind of in the future is kind of at the top of my list. And I continue, we are working really hard right now on how do we better understand where we can take our unique cases. We've had some really bad experiences over the last little bit where, we have a out-of-state network. We get minimal discounts. It kind of lets people go to all these destination type hospitals, and then we see what the costs are there as we really start digging in, and it's just crazy. And something that's really been helpful a little bit from our perspective has been the transparency that hospitals are under to be able to show both code level and DRGs and the like. And so we're working really hard right now to better negotiate deals at the front end so we don't have these multi-million-dollar deals potentially on things that we could have done better on if we were on top of our game more.
Have you guys, and maybe you already have, and I should know this, but have you guys looked at and implemented centers of excellence across the nation for specific types of services so you can avoid some of the big sticker shock issues folks have when they go out of state?
Yeah, so we're in we're in Utah, right? And we will send out quite a bit to Mayo in Arizona for second opinions and those kinds of things. So we feel pretty good about that relationship. When we compare it to what we pay in Utah and all those kinds of things, it makes sense. It's when you get to transplants, it's when you get to certain childhood diseases that are only done at a particular and some of those you just can't navigate. But we're trying a lot harder to, and maybe we've just had more, and frankly, I've just really focused on that issue, and I have for a long time. But I've started putting like my top people in charge of that. So my executive team, right? I've got a couple people around the table, and 2 of the 4 people around the table, have primary responsibility on this issue, just because the money is so significant. And if we really do a good job at the beginning, I think that we're doing a better job for the folks we serve.
Awesome. No, that's great. So what's the next big opportunity for you, Chet? What's the next big opportunity for Utah? Anything you can reveal to us today?
Yeah, well, I think, I do think, the gene therapy drug's a big deal. I'm hopeful of maybe partnering more. So what's interesting about us is that, within the state of Utah, we're really limited to public entities. And, we're not so limited when we get outside of Utah in terms of our ability to maybe work with other public entities. And,
Gotcha.
and there's a lot of us that connect in different ways. Well, I'll just give you an example, I mean, whether it's the gene therapy idea, can we kind of create some kind of way of jointly funding these things, right? Creating our own, in a sense, reinsurance type pool, right? But maybe there's opportunities for us to, um, maybe contract one off on certain drugs, right? So we try to do that ourselves. We go to drug manufacturers ourselves and say, hey, can you give us this? And we've been able to work out the contract language, and maybe others maybe haven't so much. But this idea of coming together, it can be really hard to bring the PBM together and your formulary together and all these other pieces. That can get a little bit more challenging. But what if we just agree, let's go and see if we can jointly purchase this drug all together and say, you know what, we don't need a red bottle and a blue bottle for insulin. We just need X bottle, right? What can we get a better deal through volume as a result of going directly to manufacturers on things like that? Because we're willing to, again, reduce choice in order to get greater cost efficiencies.
And I like the point you made there. It's one of the things that a mentor of mine had told me years ago. He said, how do you eat a whale? He said, one bite at a time.
I agree.
You just take that one first drug, the one drug that's on everybody's mind, or maybe it's not the top one because they've got so much power to negotiate, but it's somewhere in the top 25, and you come together and you look at how you collaborate and make that purchase and leverage that enhanced population size. I think it's a brilliant idea.
Yeah, it's very, very strategic partnerships on very specific issues where it's not that hard, rather than trying to integrate everything up. And again, I think, those gene therapy drugs may bring us together sooner than later, just because the costs on those are just really significant. And again, if you are a city, even if you have, 20,000 employees or something like that, or a university system or those kinds of stuff, the market is starting to respond in that space, but it's not doing it in a way that would be consistent with how we'd want to do business, because we're a health plan. We care about the MLR being like this, making sure that the money going out is actually to pay for claims, not to pay for us. And anytime you get into reinsurance, the amount that you pay just for the benefit of being able to see the risk is just, it's really high. I mean, it's really high. And so if we're able to come together and do that, then we're not paying an awful lot in excess administrative fees.
Good points, all of them. I remember when I was running my plan, it was always an argument between our fully insured carriers and, of course, us being self-insured about what the appropriate rate renewal should be when my MLR, medical loss ratio, I think we were at 4% on top of the claims is what we were paying for administration. And it was something that, of course, no fully insured carrier would ever agree to. I think the Affordable Care Act gives them 15 for large group. So, and they stuck to that 15, but all good points. I can tell you from my own personal experience that I've learned everything that I know in life through failure, not through success. So if you could go back in time, like what would you change in managing your health plan and why?
Yeah, good question. So when I came on board, we were a little bit in a tough situation. We'd had a legislative audit that had come through, and essentially the third rail for PHP is if we take the state and we somehow subsidize other groups, the state has no problem with us expanding our business into other public entities that want to do business with us, but they just don't want us to get any advantage of doing that. And clearly they don't want to pay, they use their tax monies to help out the cities, right? The cities have their own taxing authority, and if this is really that important, the legislature thinks that they ought to increase their tax rates rather than come to the legislature and ask for it, right? So as a result of that, we'd lost some business, and I'm very hypersensitive to our administrative fee that we charge on a PMPM basis.
Right.
And luckily for me, we had an awful lot of senior people left. Just as I came on board, I didn't take it overly personal. It was okay, right? And then I went through and I just slashed contracts left and right that I didn't believe were giving us value. We've got a really good RX program, and we still had a consultant on it. And I mean, my RX program is really good, right? And we were doing some stuff outside data, and our data folks are good. Our data folks are so good. I mean, our RX people are so good that we saved the state like $260 million over 10 years and brought our rate almost half of that of our PBM's block of business, right? And my data guys are good enough that we've created our own in-house cost tools. right? So you can see medications and everything else, right? The actual in-network rate right there for you, right? So, I was kind of letting things roll and really trying to get rid of all the external things, really focus internally, and just holding everything down. And I think at some point I probably held down a little too long because, you're only as good as your people. And I needed some other help in some areas. And with time, we've been able to piece back some and added some really good talent. If I could have added that talent maybe a little sooner, that would have been good. But at the time, you just have to jump in, right? And the good news for us is that our business went from a low of like about 128 back to we're up over 170,000 now. And so that's meant that we've been able to hold our admin fee for everybody because we've been able to increase our costs, but have like the additional lives kind of cover that up for us.
Right.
So I think it was just that transition piece and again, recognize the importance of good people. And it's really helped me in terms of my management of the organization to have a few more people that I can rely on to share more of the load.
Oh, good. Really good. I remember it's either one of the two problems that all of us deal with. You either don't bring in talent quick enough, or you accidentally keep folks that you shouldn't too long.
That's totally true, especially in our space in the public sector.
Right.
Yeah, I mean, you look for opportunities rather than creating them sometimes, and that can be hard.
Exactly. So what I'd like to do is kind of wrap up, especially for folks I think that are going to watch this. It's a great perspective you have from 170,000, 160,000, 170,000 population plan. But I think there's going to be folks that are going to be interested in hearing about what you're doing in the 2,000 population range, those public school districts, those cities and municipalities, all the way up to, the 700,000 giants that exist out east. And what I was hoping that you might be able to share some more words of wisdom that is really, I don't want to say generic, but it's really synergistic across all different plan sizes. If we have a new plan benefit administrator, you're walking into the job day one and you don't have the background that you have, and you don't have the background that I have, and you're sitting there like, oh my goodness, what did I sign up for? When you figure out that you've got to learn everything very quickly, what would you recommend a new health plan administrator start concentrating on first?
Yeah, know where the money goes. You know, um, and and that's in a couple of different ways. The first thing is know how much you're paying for choice. Um, you know, Site of service is a big deal. You can get an MRI on your back done here in Utah for like $300 at a freestanding imaging center, and you can go down the street at a rural facility, and it might be as much as $6,000.
Yep.
And so, understanding the cost of choice, right, in terms of where do you want that to be? Laboratories, labs, do they really need to be done in the hospital? You just have to understand those issues. Somehow getting your arms around drugs, especially drugs and the like. Understand where the rebates are. Make sure the contracts are really important. We just had a legislative audit that confirmed that we get 100% of the rebates from our PBM, and we give 100% of those on to folks. I mean, there's places where that can be a real challenge. Um, and then on these really big bills, you just you have to try to get in front of them rather than behind them. And if you're with a larger health plan, hopefully they do a really good job of that in the front end in terms of having good contracts with the right folks and those kinds of things. Sometimes we're in a self-funded environment. They don't manage it as closely as you'd like them to, because it's not their money, so to speak.
Right.
But you've got to know where the big things are, and it's not just to know that where the trends are. It's really, so where can I make a difference? One of the things that we've done that's been really fun is that we try to have an actionable report that we give all of our groups once a quarter. Where is it? Where do they benchmark with other folks? Whether it's diabetes management, whether it's site of service, whether it's those kinds of things, right? But there's a lot of high cost things out there. We just had a situation where we have a really expensive out of state situation where by us negotiating directly rather than just going with kind of what our network discount would be, we've saved $70,000. And that's money well spent. So I know I'm saying a lot more than just one thing, but
No, and it's fair because
don't-
it's unfortunate. Everyone's going to approach it a little differently. As you're talking, I was thinking about this, Chet, that walking into a large health plan, you have access to teams, you have access to partners where you can get really good utilization reports. You can get that data. Maybe you get it from an internal system, or you
right.
get it from an actuarial or consultant or something like that. But I'm thinking if you're a smaller health plan, one of the things that, and tell me if you agree with this, is
Yeah,
you're most often relying upon the carrier to provide you with data and detail on your population. And
right.
I think that it's fair and safe and appropriate, and almost it should be required that you push back on that data, that you ask more questions, and you try to, and you don't just take it at face value and say, well, this is the report I got last quarter. Here's the report I got this quarter. It looks like we're raising rates next year. But instead ask, what are you guys doing to manage this increase? If you're coming back to us as the carrier and you're saying these costs are going up, so I have to pass it on to you guys in the form of a fully insured rate, that your population is sicker, here's your risk score. There's all these things that you get when you work with a fully insured carrier, especially as a smaller organization. I think there should be, and tell me if you agree, a little bit more of pushback saying, well, what are you going to do about this problem that my population is having? And how are you addressing the total population health so we
Right.
can get these costs down and become more sustainable year over year? Would you agree with that?
I do. And so, I think data is critical, right? And then I think this idea of partnership is really important too. So, so we have different clients, right? And, Salt Lake City has been a client historically that has been very willing to get very engaged because they needed to, right? And so, every day I go to work, whether it's here in my office, my number one thing is to try to avoid surprises for members. I don't want surprises. I want to help them navigate healthcare, and I want to keep their costs low, right? And so I'm continually thinking about those kinds of things. And part of my challenge is, how do I interact with a group so that they're with me completely,
Yep.
right? So, and so, because I try to educate, I've got a website, I've got all these tools. I mean, we haven't talked about cash back. We give people cash back, not only just in, maybe we did, not just when they go to Tijuana, but also when they go and they get their MRI done for $300, we'll give them $200 because they didn't go to the hospital, right?
And charge you $6,000. Of course, you're saving out big time by doing that.
Big time, right? But this point of how do you get everybody on the same plan, on the same page, right? Right. So what's interesting is that what you described to me, Damon, that I agree with, is a lot of times you feel like the administrator's like, what can I do? And aren't you helping me? Right. And you should be able to expect help, but the help also should be to be able to say, so how can I help my own people? Right. What can I do? And again, that's part of one of the concepts we've had on that quarterly report, because we send things to the employer saying, here are things that you could do. Here's an area where you could do better than others, like with ER utilization, right?
Yep. You can push telemedicine, virtual visits. You can
Yes,
send out
yes,
notices through your HR department.
yes,
You
yes.
can reach out and hold, flu shot clinics. There's all kinds of things that you can
That's
do
right.
to lower your costs. Yeah, totally. I get it.
That's right. But if you can take up that piece too, and then you get a good partner on the plans, that's doing the claims and doing that day-to-day stuff for you, that's, to me, that's pretty good. And
No, that's awesome. I've kept you for probably longer than I anticipated, Chet, and I can't thank you enough for participating on this with me today. This is my first one of these, and so everything is going to be judged against this high standard of the conversational skills of Chet Loftis and
oh,
and all of the information that you threw out at us, and I really appreciate it so much. And I'm just kind of curious, Chet. I don't want to put you on the spot. I won't post your personal cell phone number. I do respect you, but if there's any administrator out there that hears what you have to
absolutely,
say and has some questions, can they shoot you an email
of
and
course,
get a little bit of information
of
from you to
course,
learn from the wisdom of a 10-year plan administrator,
yeah.
lawyer, almost legislator, right?
Yeah.
I think that would be really awesome.
No,
Thank you so much.
I'd love to help. Yeah, that would be an honor for me if anybody would like to share stories and strategy and the like.
Always good times to talk with you. Always great hearing from you. Miss
Yeah.
going out and hanging out with you when in those traveling circles that we used to, got about almost a year ago now. and look forward to when things settle down to come and sit down with you, and we can talk shop, or we can talk family, or we can talk BYU.
Hey,
So,
I like the last one, man.
awesome, man. Take
We have
care.
some good too. So
Yeah, I
that's awesome.
appreciate it, Chet. Thanks for
Thanks, Dave.
joining today. All right.